And we'll start on page 35, lab values. You have to know your lab values. But the good news is you don't have to know them all. Just certain ones that everybody else knows. There's kind of more bad news, and that is not only do you have to know lab values, but you have to know which lab values are more dangerous than what other lab values. So if you knew 10 lab values, you need to know which ones are high priority, which ones are middle priority, and which ones are low priority. Because they will ask you to prioritize people according to their lab values. Like they'll give you 4 different patients: a patient with a potassium of 7.4, potassium with a pH of 6.8, a person with a hemoglobin of 10, and a person with a BUN of 54, and they want to know who's your highest priority patient. That kind of thing. So it's not good enough just to know the values themselves, because they will give you 4 people, all of them have abnormal lab values. All of them do. So what you have to do is then rank them, on who's highest, who's lowest priority. So what I want to do is teach you that, because I don't believe any school I know of teaches students how to prioritize lab values. They teach you the lab values. They teach you the numbers, the ranges, what's normal, what's abnormal. They teach you what high means, what low means. They teach you the significance of the test, but they don't teach you that a hemoglobin of 7 is a higher priority than a person with an INR of 3.4. Do you see what I'm saying? They don't get to that. Now, am I mistaken? Are some schools doing that? Are any schools doing that?
They pretty much use that potassium, but that's about it.
They just say potassium's bad.
Yeah.
And that's probably on boards, that'd probably be the least you should know, at least that. But I'm going to give you a scheme here. Do you see the legend at the top of the page where it says A, B, C, D? A means that it's not a priority. It's a low priority. It's not a big deal. Yes, it's abnormal. The lab is abnormal. But really, there's nothing you need to do about it. In fact, in real life, what I'm going to do is, let me back up. What I'm going to do is, for every lab value I give you, I'll tell you whether the abnormal is an A, a B, a C, or a D. I'll assign a priority letter to it. Are you understanding where we're headed with this? And when I tell you that a lab abnormality is a level A, what I'm trying to communicate to you is that yes, it is abnormal. And yes, it could mean there is the presence of disease. But in the scheme of things, this is really no big deal. In fact, you don't have to do anything about it. In other words, if a lab report came back and it's an A level, you could ignore it all night long and have the doctor discover it in the morning, and you wouldn't be in any trouble for having that happen. Do you understand what I'm saying? However, if I tell you it's a C level C, letter C, and you do nothing about it all night long, and the doctor finds out about it in the morning, you are in major trouble. So I'm trying to give you a feel for how important it is that you must report these or do something immediately. So an A is abnormal, yes, but you do nothing about it, it's no big deal. A letter B, it is abnormal and you need to be concerned, but there's nothing you need to do. You just kind of watch them closer. Have you had the experience where you had a lab value that was abnormal, but it really wasn't all that bad? So you didn't have to do anything, but that lab abnormality said to you, watch them closer, watch them closer. That's what I'm trying to tell you a B is. When I tell you that a lab value is a C, we've now crossed a line from low priority to high priority. When a lab reaches a C value, it is critical. You must do something about it. You can't just sit on that lab value and do nothing. If I tell you that a lab abnormality is a D, I'm trying to communicate to you that it is the highest priority that you can possibly have with a lab value. So what's the lowest priority?
A.
Followed by
B.
And then what are two high priorities? C. And the highest of all is D. Okay, so just so everybody know where we're headed here. Okay, now, let's start into this lecture. In the first column, there's the name and anything I want to tell you about it. In the middle column, you'll write the range, the normal range. And in the last column, we'll assign the A, the B, the C, or the D. Alrighty? Let's talk about creatinine. I told you 2 days ago that it is the best indicator of kidney or renal function. Now, in this case, I am talking about the serum creatinine because they will not give you the values for a creatinine clearance, 24-hour creatinine clearance. They aren't going to test you on that, but they will test you on the serum creatinine. Now, the serum creatinine is 0.6 to 1.2, which is actually the same numbers as the lithium range. If you recall that from yesterday, the lithium and the creatinine are the same range. Okay, in the middle column, you have that. In the last column, an abnormal creatinine is just a level A. You would never prioritize a person with a high creatinine as your highest priority. Now, do they have kidney disease? If they have a high creatinine, yes. But are they going to die in the next 4 hours? No. The next morning, the doctor could come in and go, oh, his creatinine is high. He must have kidney disease, and that's fine. You're not going to be in any trouble for it. Probably the only time that I would ever make a high creatinine something that I would actually make a phone call to a doctor about is if they were going for a test that had a dye in it that next morning. Like, for example, if they're having a cardiac catheterization where they put the dye in, if the question tells you that they're to have a dye procedure in the morning, I might make a high creatinine something that I would report, but it wouldn't be in the next hour. It would just be sometime, like for example, if you got the high creatinine back at midnight, I wouldn't call the doctor till 5 or 6 in the morning at the earliest. I might wait till 7. I certainly wouldn't call him at 1 in the morning. But there are certain lab values you're going to see where you call them right away. So this would, even then, it wouldn't be a super high priority, but it would be higher than just a plain high creatinine. Does everybody understand that? Okay. The INR, the International Normalized Ratio, it monitors Coumadin therapy. It's like the PT. It's a variation of the prothrombin time. Its normal range should be 2 and 3, in the 2s and 3s. In other words, you want your INRs to be in the 2s and the 3s. Like 2.1, 3.8, that's what you want. In the last column, anything that's above 4, or 4 and above, is a C, which means it's high priority. You have to do something. This is not one you can ignore. You can ignore the creatinine, but you cannot ignore this one. An INR of 4.2 would be a higher priority than a creatinine of 30. Now, when I assign something a letter C, what do I say are the implications of that? It's critical and you have to what? Do something. Now, the question you should be asking is, well, what's the do that I should do? Well, whenever you get a situation where they want to know what are you going to do about something, there's a protocol you need to follow, an order, because this would be a click and drag. You always hold. That's the first thing you do. What do I mean by hold? If there's something that's causing a problem, stop it first. After you hold, then you assess. What would you assess? A whole, complete, head-to-toe physical exam, yes or no? No, a focused assessment. Focused on what? The area that the lab value is telling you there's some problem with. But do a focused assessment. Then you prepare, which means you prepare to give. Now, you don't always give, but you prepare to. And after you prepare, then you call, meaning call physician, or call respiratory, or call whomever is appropriate. But before you call the physician, you always hold, assess, and prepare. Now, if we apply this to the INR of 4.7, let's say you get an INR of 4.7, and they want to know what are you going to do, in what order, and you have to click and drag. What would you click first? Hold what? Hold Coumadin. Hold all Coumadin. Then what would you do? Assess for what? Bleeding. Then you would vitamin K, prepare to give vitamin K, and then you would call your doctor. In that order. Now, sometimes there may be nothing to hold. Do you understand what I'm saying? There's nothing to hold. There's nothing causing a problem, so you jump immediately to what? Assess. And sometimes there may not be anything to prepare, so you jump to call. But you should intellectually go through that process with everything you do something about so that you're thorough, so that you don't miss a step. All right, potassium. Potassium, there's nothing I want to say about it in the first column, except that it's not really a good indicator of anything, but it is an indicator that something's wrong, but you don't know what. Its range is 3.5, and then flip it around 5.3. 3.5 to 5.3. Now for Hesse, it's 3.5 to 5.0. For Hesse, it's 3.5 to 5.0. But for boards, it's 3.5 to 5.3. Why? Why the difference? Boards is a nationalized. Hesse uses whatever Elsevier lab book says. Okay? So, to Hesse, a 5.1 potassium is an elevation. On boards, a 5.1 is not an elevation. Now, let's talk about the last column. A low potassium, meaning lower than 3.5, is a C. You have to do something. Okay, now let's go through our protocol. If your potassium is low, is there anything you have to hold? No. So what do you do? But what are you assessing? What's your focus? Heart. Assess heart. Prepare to administer vitamin K. Potassium. I always do that. I always used to do that. Anybody ever do that? Vitamin K and potassium K? I screwed that up for like 10 years. Okay, and then I what? Call the doc. All right. What if it's between 5.4 and 5.9? That gets a C. So now you have to do something. Well, is it high or low? High. So what do you think we would first do? Hold all potassium. And that may mean ripping down the D5W with 20 of KCl. You know what I mean? Getting that torn down. Then you assess the heart. Then you... What? Now, Lasix does make you lose potassium, but we don't give Lasix for the purpose of losing potassium. Kxalate and D5W and regular insulin. Remember yesterday? Kxalate and D5W and regular insulin. And then you call your doc. However, in the last column, if the potassium is greater than or equal to 6, it's a D. It is deadly dangerous. This person could die soon, like in the next 2 minutes. So what do? You do everything we just said. You rip down the IV, you assess the heart, you prepare the D5W, regular insulin, and the K-oxalate, and you call your doctor. You do all that what? Stat. So how many people have to be involved? You probably got one nurse ripping out the what? Potassium. You got somebody calling for an EKG coming. One nurse is preparing the D5W and regular insulin while the secretary's calling the doctor's stat. Do you see what I'm saying? And you stay with your patient. Got it? Because you can't leave the bedside of a D. You understand what I'm saying? Can you leave the bedside of a C? Do you even know what I'm talking about? D's and C's. Okay, got it. Okay. Can you leave the bedside of a C? Yeah. Can you leave the bedside of a D?
Nope.
No. So one of the things you're going to have to remember when you're answering these D questions is you stay at the bedside and you do what you can do at the bedside, but everybody else helps you do everything else. You don't run out and get the EKG and leave your patient by themselves with a potassium of 7, okay? Now, I'm not saying you do this in real life. You should do it in real life, but I'm saying this is what the book wants you to do. And really, if you really did this, you wouldn't get in trouble. Your patient would be in good shape. Okay, the pH, 7.35, 7.45 is the range, which you told me the other day. In the last column, the only thing that matters is a pH in the 6s is a D. Now, I don't mean 7.6. I'm talking about 6 point something in the 6s. Now, you notice that do you notice with the creatinine, I didn't talk about a low creatinine. Did you notice that? And in an INR, I didn't talk about a low INR. And here I'm not talking about a high pH because those aren't that clinically significant and they're not usually tested at all. You see what I'm saying? These are the things that are tested over and over and over again. So rather than have you learn everything, let's focus on what's essential. Alrighty, pH in the 6s. So what do? Is there anything to hold? I can't think of anything. What would you assess? Now this is interesting. What do you think you'd assess? Somebody said respiration, somebody said pulse. There you go. Lump them together, check your vital signs. Because the pH is going in what direction? Down. And as the pH goes, so goes your patient. So the patient is going to be going what? Down and out. And you're checking, with a pH in the 6s, to be totally transparent and honest with you, you're doing the vitals to make sure they're still alive. I know that sounds ridiculous, but you really are. Because, usually when you have a 6, you're dead. So you're just making sure they're alive. And then is there anything to prepare? Not really. Used to be, years ago, because they were severely acidotic, we would prepare bicarbonate to give bicarb, but you don't do that anymore. You don't indiscriminately give bicarbonate like, if you've ever been taught that, no, you don't do that. You don't give bicarb anymore to acidotic patients because it confuses the whole issue. The key is to correct this acidosis. The only way you can correct it is to treat the underlying cause. And there is nothing a nurse can do to treat the underlying cause. The physician has to get here, determine the cause, and treat the cause. So, with a low pH, you have to get the physician in on the case faster than anything else we'll talk about today. So, that's why you just assess their vital signs and you call your doc. And you skip hold and you skip prepare. Now, why are you getting the vitals?
Sure they're alive.
Because when you call the doc, what are they going to say? Is he alive? Is he breathing? What's his heart doing? So get a set of vitals. That's all you need. Set of vitals. Call the doc. And you stay.
With the patient.
So who gets the vitals? You do. Who calls the doc, maybe some, put on the light or whatever, and however you communicate to your secretary, unit secretary, and have them call stat. Okay, BUN, blood urea nitrogen, BUN. It has a lot to do with nitrogen waste products in the blood. Its range is 8 to 25. 8 to 25. The way I remember that is BUN spells what English word? Bun. Buns, like hamburger buns, hot dog buns. When you buy hamburger buns or hot dog buns, how many are in the pack? 8. There's your 8. Buns, 8. 8 to 25. And if the BUN is elevated, it's no big deal. All you do is assess them for dehydration. Assess them for dehydration. By the way, a little hint. Good guessing strategy here. If they give you an elevated blood value and you have no clue what's going on, and they ask you, for what would you assess them? Dehydration is a great answer. Because when you dehydrate, what happens to all blood values? They go up because of concentration. So it's just a really good guess to say, when the BUN's up, I don't know what it is. Well, pick dehydration. Good answer. You may be wrong, but it was a good answer. Might not have made the top 10 surveyed, but it's not bad. I don't know why I had an extra L on the end of elevated, but Hemoglobin is the next one. It's 12 to 18. Now, I know it's 12 to 16 for women and 14 to 18 for men, but for humans, it's 12 to 18. And boards doesn't get into lab values versus men versus women, children versus adults, newborns versus. They could be on your test, but those are really hard questions, and you do not have to get those right. But if you don't know a normal adult hemoglobin, you're in trouble. Okay. If it's 8 to 11, if the hemoglobin is 8 to 11, it's a B. And you would assess them for what? Low hemoglobin. Anemia, a bleeding or malnutrition. If the hemoglobin, however, falls below an 8, it's a C, and you must do something. Okay, well, what are you going to do? You going to hold anything? Not that I know of. You're going to assess for bleeding. You're going to prepare to administer blood, and you're going to call the doctor. Now, LPNs, you would prepare, but you would call, not on this, but on everything where we've said call doctor, you could substitute notify RN. Do you see what I'm saying? You could, wherever this could say hold, assess, prepare, notify RN. Alrighty? Bicarb. The bicarb is what? 2 plus 2 plus 2 equals 6, right? 22 to 26. And an abnormal bicarb is an A. We don't care. So what? I've never, in 37 years of being a nurse, I have never been yelled at by anybody because I didn't tell them what somebody's bicarb was. It's just not a major issue. Okay, CO2, carbon dioxide. This you are getting from an arterial blood gas, by the way. The normal range is 35 to 45. It's the same as the pH, just dropping off the 7 point, correct? In the last column, a CO2 that's high, but in the 50s, like 51, 57, 56, 59, those are C levels. That's a C, which means it's critical. You can't just sit on it. You got to do something about that. That's not good. Now, I want to say a disclaimer. I'm not talking about COPD clients here at all. that changes everything. This is for people without COPD. So what do? Well, is there anything to hold? A high CO2, anything to hold? I don't think so. What would you assess?
Respiration.
Respiratory status. Now, when it comes to prepare on this one, there is actually something you can do. There is actually something you can independently, as an LPN or an RN, do. What would that be? Okay, breathing in a bag actually recirculates the CO2, so we don't want that. That would be raising the CO2. What's that? Oxygen is used for low oxygen, not for high CO2.
Navel down,
What's that?
look down like on your thumb, where you're, I read that if you actually put your thumb in your mouth and blow.
Oh yeah. Okay, like your, yeah. Or they'll say the candle. This is a candle. Blow out the candle. That is called pursed lip breathing. Have you heard of that? This is what you're going to pick. Pursed lip breathing. Because with pursed lip breathing, you're prolonging the exhalation. And if you prolong exhaling, you're getting rid of CO2. Now, most of the time, that will correct the problem, so you never have to move to what? Call. How do you know it's going to correct the problem? They will breathe easier. Because when they're in the 50s, it's going to be dyspneic. They'll be dyspneic when their CO2 is in the 50s. So that will solve that problem. However, what if the CO2 is in the 60s? That's a D. That's one of the criteria for making the diagnosis respiratory failure. Have you heard of respiratory failure? Well, how do you know someone's in respiratory failure? Well, one of the ways you know is the CO2 is 60 and above. Now, here again, we're not talking about COPDers. So this is a medical emergency. This is a super high priority patient. So you do not what? Leave the room. You stay with them. So is there anything to hold in this case? Nope. Assess their respiratory status. Now, pursed lip breathing isn't going to cut it. Now, I will probably do it with them just to decrease their anxiety and maybe take the edge off of it. But I'm going to have to prepare for what? Two things, because they're in respiratory failure. Intubate and ventilate. So you prepare to intubate and ventilate. And then who do you call? There's two people to call. Who do you call first? Respiratory therapy first. Call respiratory therapy first. Then call the physician. But you stay with your patient. Yes?
At that point, would you also call the emergency response team? Or does that come later?
Like a code?
Well, I got pre-codes.
A pre-code? Yeah. On boards, they really don't have anything that's called an emergency response pre-code team. They don't. Certain hospitals have that, some don't. And because it's not a universal phenomenon across the nation in every hospital, they won't even go there. But I would say if I were you and I had one of those teams at my disposal in a hospital, yes, at this point I would, because this person's going to end up on a vent. And that's the best that's going to happen. You know, the worst could happen before. So, yeah. All right. Hematocrit. Hematocrit is 36 to 54. 36 to 54. Now, I don't remember that. That's why I had to think for a few seconds before I said it. I never remember that. because that's a clumsy number, 3654, it's just sloppy. Well, it's 3 times the hemoglobin. So whatever the hemoglobin is, multiply that by 3, and that's why I had to do the math in my head there for a second before I told you. So 12 times 3 is 36, and 18 times 3 is 54. So it's 36 to 54. Okay, an elevated hematocrit. An elevated hematocrit. It's abnormal, it's a B. An elevated hematocrit, what would you assess for? Dehydration, good job, dehydration. But it's no big deal. Okay, let's talk about the oxygen level, the PO2, the oxygen level. Here again, you're getting this from the arterial blood gas. This is not what you're getting when you put on the pulse ox on their finger or their earlobe. That is not the PO2. The PO2 is from the blood gas. Now the PO2 normally should be 78 to 100. 78 to 100 is the normal range. If it is low, but still in the 70s, like 70 to 77, that is a C, which means you have to do something. It's critical. So, is there anything to hold? No. You assess what? Respiratory. Now, there is something you can do, both LPNs and RNs, without a physician's order. And what is that? Give them oxygen, because their oxygen is low. So now you give them oxygen. And 9 times out of 10, what will happen? Will it correct it or not? It will correct it, and you will not have to call your physician. And how will you know it corrects it? Because you're not having a continuous arterial blood gas measurement. You'll know because the dyspnea goes away, and the restlessness and the anxiety and the tachycardia. By the way, just an interesting thing so I know everybody knows this, because they love to test this. When someone is hypoxic, which rate increases first? The respiratory rate or the heart rate? Heart rate. So when you go hypoxic, your heart rate will speed up first. Then, when the heart can no longer compensate for it, your respiratory rate goes up. A lot of people think, oh, hypoxic, your respiratory rate will go up first. No, it won't. Your heart rate goes up first. If you ever work coronary care, what are the 2 most common causes of episodic tachycardia in heart patients? Hypoxia and dehydration. So a coronary care nurse knows that when you get these episodic tachycardias, all you have to do is increase the IV rate and give them some oxygen, and it goes away, and you never have to call your doctor. I would have to say 90% of the time that I have episodic tachycardia in the coronary care unit when I worked night shift there for 10 years, was at Mercy Medical Center in Springfield, now called Springfield Regional whatever Mall. I never had to call doctors because I would just up the IV rate or give them oxygen, and the tachycardia would go away. You always could tell a new nurse who came into coronary care because they were calling doctors in the middle of the night for episodic tachycardia. And the doc would say, well, did you increase the IV rate? No. Did you give them oxygen? No. Well, do that and call me back if it doesn't work, And that, I'm saying it politely. Okay. Okay, well, what if it's low in the 60s, meaning 68, 69, 64, 63? That's a D. That's the other criteria for respiratory failure. So what are the 2 defining characteristics for respiratory failure? CO2 in the 60s and an O2 in the 60s. When they're both in the 60s, that's when you need to intubate and ventilate them. So, if it's in the 60s, there's nothing to hold, you assess the respiratory status, you prepare to intubate and ventilate, you call respiratory therapy, and you call the doctor. Now, you can put oxygen on them during that time. It's not going to solve the problem, but it's going to make them a little more calm. So if I had a click and drag on that one, where would I put the oxygen? I'd probably do this. I'd probably hold. I wouldn't hold anything. I'd assess. Well, no, there's nothing to hold. I'd probably throw on the O2 just to make them what? Comfortable. Then I'd assess them, and then I'd prepare to intubate and ventilate, call respiratory therapy, and call the doctor.
Or
Yeah.
that kind of confuses me because I was always taught, I guess, to always assess first and you're safe. Like in any question, if you
No, you're not. That's a gross oversimplification.
Okay.
She said that she was taught that in an order question, you always assess before you do. And that's true 80% of the time. 20% of the time it's wrong because there's something you need to hold before you assess. For example, you're giving a blood transfusion and somebody complains of itching and you see hives. What do? Stop the blood, then you do your assessment.
What about though in this situation, because I would have put assess my patient first, then do put the oxygen on that.
That would probably, I don't think, just in my impression, I think if you asked 50 nurses, you'd have half and half on that. And so I can't conceive that they would write that question on boards because it would be such an interpretive thing, subjective kind of thing. But if the INR is 5, every nurse says, I'm going to stop the Coumadin and then I'm going to find out, assess. That they would all say that. And if the potassium's 6, they'd say, I'd turn off the IV and then assess their heart.
Okay, that makes sense.
So yeah, it's going to be, there are certain things where I always tell people this: assess before you do, unless delaying doing puts your patient at higher risk. And if you would assess for signs of blood transfusion reaction, if you delayed stopping the blood to do an assessment of are they having a reaction, you would be putting the person at increased risk. So therefore you do before you assess. So what's the rule, everybody? Assess before you do, unless delaying doing in order to assess puts the patient at risk. For example, a patient pulls out their arterial line. They are bleeding in bright red spurts from their radial artery. What's the first thing you do? Assess their vital signs. Apply pressure. Okay? Well, one's assess, one's do, right? Well, if you delay putting pressure in order to take a set of vitals, are you increasing the risk to the patient? Yes, therefore do will precede assess. And that's an obvious one, but I'm trying to illustrate the principle. Are you seeing that?
Yeah.
Okay, good. Good question, because that's one that everybody's taught. How many were taught? Assess before you do, assess before you do. But you have to understand, whenever you use a rule like that, you have to understand that there's always an exception, and what's the exception? Yes?
Dr. Carmel group always had a question on ATI that would always catch us up, and it was something about with respiratory situation, which do you do first? And it had head of the bed,
Yes.
and oxygen, and
Yeah.
talking about assessing and calling the doctor. et
Yeah.
cetera.
The thing is if I was between somebody's having dyspnea, acute dyspnea, one was elevate the head of the bed, the other was put on oxygen, the other was call the doctor, and the others do a respiratory assessment. What would I do? I would elevate the head of the bed first. Alrighty? I I'm getting data that's not going to be helpful. He's not going to cooperate with me. I'm not going to get good data. I'm not going to get full. So I'm going to elevate the head of the bed first. I always like to do, if I'm between two do's, I like to position first. You know, if I'm between two do's and one's a position and one's another action, I find that the position usually wins over the other action. How many have found that out, sort of seen that? So I would probably elevate the head of the bed. I would put the oxygen on. I would do an assessment, and then I would call the physician. Now, what did ATI say, I wonder? Is that what ATI said? Mhm. Because I almost always position first. When I'm between what? Two do's, I always position first. And see, my rule there would be, if somebody's in significant dyspnea and hypoxia, would delaying putting their head up and delaying giving them oxygen while I did a respiratory assessment put them in greater risk? And the answer is yes, you would be. You see, so then I would precede the assess with the do's. Do you see that? Yeah, question.
So if you raise the head of bed first, what you do best is give them O2.
Bingo. You're smart. Good job. Did you hear what she said? She said, but what if it's not a first question? What if it's a best? And you're between oxygen and raised head of bed. Well, in a best question, and I'm really glad, are you here for a refresher, or is this the first time you've taken this class? First time? Good job. Because if you had to do one, raise her head without giving her oxygen, or keep her flat with oxygen, she really will benefit better from the oxygen lying flat than she will up with no O2. So best would be O2. First would be raise head of bed. Is everybody seeing that? Good call. Okay. The O2 sat, the oxygen sat should be 93 to 100. Anything less than 93 is a C. Critical. There's nothing to hold. You assess them, you throw on the O2. Now you could, I don't think with an SaO2, unless they're in real danger, a low SaO2 is not going to, like an 88, there's no reason to throw on the O2 right away. You know what I'm saying? I don't, there's no big deal there. In fact, I can't even believe I'm telling you that an SaO2 below 93 is that bad. Because I'm happy with SaO2s of 88 and above. If you think that you're going to run around calling doctors in the middle of the night for SaO2s of 91, you're not going to last long. But on HESI particular, and on boards, if it's a 92 SaO2, they're in bad shape. And I'm telling you, that's not real life. But that's the book. Do you got me? Because HESI has a question on there where it says, they give you 4 patients and want to know who's your highest priority. And I remember taking it, and letter A was a patient with a 91 SaO2. And I went, oh, that's fine, you know. And then I went to B, and they were okay. And I went to C, and they were fine. And I went to D, and they were good too. And I thought, oh my goodness, they're all fine. And I thought, wait a minute, 90, it's not 93, it's 91. So that's the one that's in bad shape. So I picked them, I got it right. So you're just going to have to go with that, all right? Now, anybody ever want to work peds? In pediatrics, you better freak out when it's below 95. Okay, because little kids don't desaturate without, older people, we desaturate all the time. You know, it's just what we do. But little kids don't desaturate.
Do they specify if it's a COPD patient?
They usually won't go to COPD because then that anything could be, with COPDers, they're going to have abnormal blood gases. But there's no pattern to tell you what it's going to be and how much of one thing means what. Do you see what I'm saying? Like they can't say, well, you know, for respiratory failure for a COPDer, it's not 60 and 60, it's 70 and 50. There are no parameters. Every COPD their blood gases are individually judged on their level of functioning at that blood gas. So if you have a COPDer with a CO2 of 59, which it should never be, and a O2 of 64, which is horrible, but they're functioning okay, then that's their baseline. Do you see what I'm saying? And the hypercarbia is no issue because they don't have a hypercarbic drive to breathe. They have a hypoxic drive to breathe, so it doesn't even matter. So that's the issue. With a little hypoxia is good for a COPDer because it keeps them breathing. That's why you don't want to give a lot of O2 to a COPD or they'll stop breathing on you. So yeah, I don't think that they could even ask a question that would be fair, other than the fact to know that COPDers normally run high on the CO2, low on the O2. So I guess my question answer to you would be, if they gave me 4 patients and they told me one was a COPDer with a CO2 of 55 and an O2 of 71, even those are letter C's for you and I would not make them a high priority. Okay. BNP. Oh, by the way, when is your SaO2 invalid? What invalidates your finger probe SaO2 reading? What's that?
Anemia.
Anemia falsely elevates it. So if somebody's anemic, they're going to look a lot better than they actually are. So if you have an anemic patient, your SaO2 is not helpful. You need to look at other indicators of oxygenation. The other thing that invalidates it is if they've had a dye procedure in the last 48 hours. Why? What does the dye do to blood? Color it. And what does that read? Color. So you're going to have falsely elevated SaO2s with anemia and after dye procedures. So in both cases, when you get your SaO2, you're going to think the patient is what? Better off than they actually are, which is actually pretty dangerous. Okay, BNP, which is the brain natriuretic peptide. Don't worry about that. It's the best indicator of congestive heart failure. It should be under 100. An elevated BNP is a B, which just means you've got congestive heart failure, but you're not going to die. You don't need to call the doctor in the middle of the night. There's nothing you have to do. Just watch them for CHF. See, it sounds kind of funny that a heart value is not a high priority, but this is a heart value because it's indicating a chronic condition. Do you understand why it's not high priority? Because it indicates a chronic condition, not an acute one. Sodium. Sodium is 135 to 145. If it's abnormal, it's a B, which means you assess. If the sodium is high, you assess for dehydration. If the sodium is low, you assess for overload. Remember hypernatremia, hyponatremia, the one with the E is dehydration, the one with the O is overload. However, if the question tells you the sodium is abnormal and there is a change in LOC, the priority of the patient shoots up to a level C. And basically, it's a safety issue at that point. It's safety. Which brings us to the last 3 lab values. Yay. You see why I didn't want to do this yesterday at 3:30? White blood cells. There are 3 white counts you must know. 3 white counts you must know. The first one is the total white blood cell count, which is 5,000 to 11,000. The other 2 are the ANC, the absolute neutrophil count, which needs to be above 500. There's no range here, it's just a threshold limit. You must have more than 500 ANCs per cubic millimeter. And the last one is the CD4 count, and it needs to be above 200. Because remember, when your CD4 falls below 200, what do you have? Not HIV, you got AIDS now. So the defining line between HIV disease and AIDS is the 200 CD4. If you've got 201, you have HIV disease. If you've got 199, you have AIDS. So all of those are low white counts. And all of those are a letter C. All of those below those levels. An ANC below 500. A white blood count below 5,000. And a CD4 count below 200. All of those are level Cs. They all are. And because of that, there's nothing to hold. You assess for signs of infection. And instead of preparing, what you do is you place them on these neutropenic precautions that are in your last column. And it would be good for you to know those, because they do test what's on the neutropenic precautions. The one that it's amazing how you could be a nurse for decades and certain facts you just never learned. It was like 10 years ago, after I've been a nurse for 20 some years, that I learned the ninth one. I think it's the ninth one down. Don't drink water that has been standing longer than 15 minutes. I didn't realize on these neutropenic precautions they are not allowed to have a water pitcher. If they want water, you bring them fresh water. No, water isn't allowed to stand. In fact, the water bottles, if they're unopened, I think they're good for 4 hours. If they're open, they're good for an hour. Yes?
I have my leadership on oncology, hematology, and insurance.
Mhm.
And I had patients who were getting BMT transplants.
Yes,
And
bone
I
marrow
had,
transplants. Yeah.
I had ANC patients with literally two. Like not
With a
200,
two.
With a two.
With a two.
And the neutropenic precautions we had to do, like this patient, the nurse, when she had this patient, you could only have one patient because
Exactly.
the precautions were so
Rigorous.
timely and rigorous. And
What did they use for the water bottles? What did they use?
you weren't allowed to have a water bottle open unless you drank it right away, and they had a special refrigerator that we were able to go. Like you couldn't just get them regular water. We had to go to the BMT refrigerator, which was always locked. We'd unlock it, get it out, bring it to them, watch them drink it, throw it out. Right
Throw
away.
it out. So it wasn't even an hour. Okay.
I mean, I think you could have for 20, 30 minutes to let the patient
Okay.
drink it, you know.
Mhm.
But there were certain, and then we had to clean the room every, I think it was either every 4 or every 6, we had to clean it
Mhm.
down with this really special, the whole
Yeah.
room. I mean, it just was
The point is they can really get more obsessive than this. A lot more. So this is sort of like the least you would do. And this is see, with bone marrow transplants, you got to be really, really careful because they're really dangerous. Because what did we do? What did we do to them? We irradiated total body irradiation. We irradiated all of their protection. They have none. Zero. I'm surprised she had 2. I've seen some with practically none. Okay, so neutropenics are really important. Okay, platelets. Platelets, I'm not going to give you a normal range because I've looked in 5 different books and they don't even overlap. Nobody knows what a normal platelet count is, I don't think. But the key is, what are the trigger values for thrombocytopenic precautions or bleeding precautions? And that is in your last column. A platelet count below 90,000 is a C. You need to put them on these bleeding precautions. And if the platelet falls below 40,000, now you'll hear people say he has 40 platelets or 35 platelets. They don't mean 35. They mean 35,000. So if they say his platelet count is 3, what do they mean? 3,000. They don't mean 3. Okay, now the ANC means what it says. But this is usually in thousands. And then red blood cells are 4 to 6 million. Red blood cells are 4 to 6 million. And an abnormal red count is just a B. It's no big deal. Okay, now that's a lot of info. Here's what I want you to do with it. Memorize the 5 Ds. Why should you memorize the 5 Ds? Because those are the really high ones that if you don't know, you're unsafe, and you don't want to show that on this test. So what are the 5 Ds? pH in the 6s. Not bicarb.
CO2.
Okay, but there's one before that. Potassium in the... So a potassium in the 6s, a pH in the 6s. Got that? Now what is the next one? CO2 in the 6Ds and an O2 in the 6Ds. So a pH or a potassium in the 6s, or a CO2 or an O2 in the 6Ds. So what pattern are you seeing already? 6s and 6Ds you don't like. And then what's the 5th one? Platelet count of less than 40,000. Those are your highest priority people. Nobody will beat them. And boards will not put those people against each other because it's not fair. Okay, now, what I would then do is learn all the C's. There's probably about a good 8 to 10 of them. Then I would not remember the priority on any of the others. Why? Because that way, if you don't remember them, they are what? Priority. Low. Do you see what I'm saying? So just remember the high ones and everything else is low. So remember your D's, which I think are easy, your 6s and 60s in the 40,000. And then your C's and probably what to do for them, and then you're good to go. And you really will be so much better prepared for the questions than anybody else sitting there. You know? So, because everybody else is just going to what? Guess. And say, well, potassium. And then if it's not potassium, they're dead in the water. Okay, let's turn to something near the back of the book. I want to get it done earlier because it's just a horrible lecture to do late in the day. And that is page 64, psych drugs. We'll do this one, then take a break. Psychotropic drugs, page 64. This is a big laundry list of psych drugs that you have to know. But don't panic, because you're going to find that psych drugs, even though the classes of drugs are different, there's a lot in common between them. And so you're not, even though you may memorize 10 different classes, there isn't going to be 10 totally different, discrete pieces of information. A lot of it's going to overlap, which is nice. And to start off with showing you this, the note in the box is very important. All, how many does that mean? All. Thank you. All means all. All psych drugs cause low blood pressure and weight changes. There isn't a psych drug made today that does not lower your blood pressure and make your weight change. Now, the vast majority of psych drugs will do what to your weight? Increase. But Prozac and a couple others make you lose weight. But even Prozac makes you gain weight. In Prozac, you can go either weight gain or weight loss. Weight loss is more common, but you wouldn't rule out weight gain for Prozac either. So if you really wanted to make it specific, you could say all psych drugs cause low blood pressure and weight gain. But you have to understand that Prozac and a couple others will also cause weight loss. Could cause weight loss. If we just stopped right there, you'd probably do better on your psych drugs, because they like to test those universal kinds of principles. But let's not do that. Let's go into the major classes more specifically. The first one are the phenothiazines. This is an old class of drug, speaking pharmacologically. They're called the first generation antipsychotics, or they're called the typical antipsychotics. Have you heard those words? Typical antipsychotics, first generation antipsychotics. Those are your phenothiazines. They all end in zine, Z-I-N-E, which I love. I think every drug should be that way. I think every drug in a class should end with the same ending, and it should be the ending of the name of the class of the drug. Okay? So all steroids should end in oid. Okay? All calcium channel blockers should have CAL at the beginning of the name. Calcium. You know what I'm saying? All beta blockers should have beta beginning in the name. All benzodiazepines should end in zapine. You see what I'm saying? I just think that's the way it should be, and it isn't, so we have to get over it. But anyhow, this class, it's great. They all end in zine, like thorazine, stelazine, fluphenazine, piperazine, chlorpromazine, hydroxyzine. All those zines are phenothiazines. Actions, they do not cure psych diseases. They just reduce your symptoms. In large doses, they are antipsychotics. I remember this by saying we use zines for the zany. Zines for the zany. So you see a drug ending in zine, what should you immediately think? Zany. It's for an antipsychotic for a crazy person. In small doses, they are antiemetics. Have you ever given compazine? Have you ever given Phenergan promethazine for nausea? Have you ever given Vistaril hydroxyzine for nausea? But if you double the dose, it will treat psychosis. Have you ever given Thorazine for psychosis? If you cut the dose in half, it will treat nausea. Letter C, they are considered major tranquilizers. Major tranquilizers. These are the big guns. I'm going to make an analogy here. Aminoglycosides are to infection like phenothiazines are to tranquilizers. Okay? I should make it different. Aminoglycosides are to antibiotics like phenothiazines are to tranquilizers. What's that mean? They're both the big guns. You pull these out when nothing else is going to work. Okay, these major tranquilizers have a major side effect list. In fact, this has been the marketing dilemma manufacturers of these drugs have had for decades. They manufacture these drugs that really work well, but they have this long list of side effects that really hinders their marketability. I'm going to use the alphabet here to help you remember the side effects of the major tranquilizers. A will stand for anticholinergic, primarily dry mouth. Anticholinergic, dry mouth. B stands for blurred vision. C stands for constipation. D stands for drowsiness. Anybody know what E stands for? EPS, extrapyramidal syndrome, the thing that looks like Parkinson's. Extrapyramidal syndrome, EPS, like Parkinson's. Remember where they get the pill rolling and the cogwheel rigidity and the shuffling gait and all that? F, I cheated. I needed the F. Photosensitivity. I know it's spelled with a PH, but I needed the F to work for me. So photosensitivity. And then with the G, I want you to put a little A in front of the G and write a granulocytosis, which means low white count. So they have a dry mouth, they have blurred vision, they have constipation, they have drowsiness, they have the Parkinson extrapyramidals, their skin burns to light, photosensitivity, and they're immunosuppressed. So that's the side effects of. Now those are all side effects, not toxic effects. What do you do when a patient displays a side effect? What's the nursing action when a patient displays a side effect? Do you hold the drug? No. You teach the patient, inform the doctor, and keep giving the pill. When someone experiences a toxic effect, what's the nursing action? Hold the drug, call the doctor immediately. So for EPS, would you call the doctor immediately and hold the drug? No, we have Parkinson's drugs like Cogentin and Artane we'll give to them to treat the EPS. The only problem is when you give Parkinson's drugs to treat the EPS, do you know what 2 of their major side effects are? Dry mouth and constipation, so that gets worse. But it's kind of a pain. All right, number 5. The nursing care is treating the side effects. So what's the number one nursing diagnosis? Well, they have blurred vision. What's the number one nursing diagnosis related to blurred vision? Injury, risk for injury, safety, right? Drowsiness, what's the number one nursing diagnosis with that? Same thing. Extrapyramidal, what's the number one diagnosis there? Same thing. So what is the number one nursing diagnosis when a client is on a major tranquilizer? Risk for injury, safety issues. Number 6 is a vocabulary word. I want you to know what the word decanate means. Decanate can come after the name of a lot of different drugs. Sometimes they'll abbreviate it. They'll say Thorazine D or something D. The D means decanate. And what decanate means is after the name of a drug, it means it is a long-acting. Sometimes it works for 2 weeks, sometimes it works for a month. 1 shot for a month. It's a long-acting IM form given to non-compliant clients. In fact, this is usually court-ordered or could be court-ordered. What do I mean by that?
They're making
Yeah, they probated the client and the judge ordered monthly Prolixin injections. Okay, it's court-ordered. So if the client does not come in to the psychiatrist's office or the community mental health center for their Prolixin shot, because it is court-ordered, what can the staff at the clinic do? Contact the police, who will put out a warrant because they're in violation of a court order, and they will arrest them, bring them in, you stab their butt, and they go home. Okay, so that's the way it goes. And the police just love that. Okay, tricyclic antidepressants. Tricyclic antidepressants are an old class of antidepressant, and most of them have now been grandfathered into a new class of antidepressants called the NSSRIs. Which means what? Non-selective serotonin reuptake inhibitors. But you understand, they were not invented as NSSRIs. They were invented as tricyclic antidepressants. But chemically, they're so much like the NSSRIs that they've sort of been grandfathered into that group. They are mood elevators used to treat depression. They are mood elevators, happy pills. Examples of these are Elavil, Tofranil, Aventil, and Deseril. Elavil, Tofranil, Aventil, Deseril. Elavil, Tofranil, Aventil, Deseril. It rhymes. They all rhyme. Do you hear the rhyme? I'm serious about this. I want you to put these on a 3x5 card. I want you to tape them to your steering wheel. And for the next 4 days, every time you come to a red light or a stop sign, I want you to stop texting, and I want you to just say Elavil, Tofranil, Aventil, Deseril. Elavil, Tofranil, Aventil, Deseril. Elavil, Tofranil, Aventil, Deseril. And after 3 or 4 days, guess what will be forever linked in your brain? Elavil, Tofranil, Aventil, and Deseril. Now, why do I want you to link those 4? Because if you link the other 3, Tofranil, Aventil, and Deseril, with Elavil, Elavil's real easy to remember that Elavil elevates. Elavil elevates. Well, what's it elevate? Your mood. So if you know Elavil elevates your mood, and you link Tofranil, Aventil, and Deseril with Elavil, then you'll know Tofranil, Aventil, and Deseril are also mood elevators. You see why I want you to link them? So that you know what they do. And Tofranil is a very famous one that they love to test. For what reason, I don't know. It's been decades since I've given Tofranil. Okay, in fact, I don't even know why they still test these drugs. They're not given that much. Okay, what are the side effects? Well, Elavil starts with the letter E, so this group's side effects use the alphabet, but it only goes through the letter E. A for anticholinergic, primarily dry mouth. B for blurred vision. C for constipation. D for drowsiness. And E is euphoria. E-U-P-H-O-R-I-A, which means happy, joy, joy. You know. Way too happy. Have you ever met anybody that's so happy it irritates you? That's what this is. What do you notice about that list? It's very similar to the major tranquilizers, but you don't have the extrapyramidal, the photosensitivity, or the agranulocytosis. But the big thing they'll ask about these antidepressants is you must take them for about 2 to 4 weeks before you get beneficial effects. You take them for 2 to 4 weeks. So do they work right away? No. So what's a patient going to say typically after 1 week of antidepressant therapy? What will they say? It's not working. And you need to teach them it's going to take a little while. Letter C, the benzodiazepines, the benzos, real famous. Everybody should know about the benzos. The benzodiazepines. These are anti-anxiety meds. They are considered to be minor tranquilizers. As opposed to what? The Zines, which were the majors, the Zeps are the minors. Number 2, they always have Z-E-P in the name. Zep. Always. So how do you tell a phenothiazine? Ends in Z. How do you tell a benzodiazepine? Zep. But both tranquilizers, majors and minors, the identifying syllable starts with what letter? Z. Zeps and Zines are tranquilizers. Now the way I remember that is in cartoons, when somebody is tranquilized, meaning they go to sleep, what do they write on the page? Z, a bunch of Z's, right? So if you want to put somebody to sleep, give them Z's, use the Z's. What Z's? The Zeps and the Zines. Zines for the zany, those are the what? The majors. And Zeps are the minors. The way I used to remember that when we were in school, doesn't work as well for you guys because you're younger. But back when I was in school, the greatest rock band of all time was Led Zeppelin. Anybody ever hear of Led Zeppelin? Who's never heard of Led Zeppelin? Oh, wow, I'm still impressed. You still have heard of it? Wow. They must be in their wheelchairs still making
Rock
music.
bands.
What's that?
Rock bands put all those older,
Oh, okay. You mean
the games.
the game is bringing it all back? Okay.
Yeah.
Well, I just remember Zeppelin. Zeppelin starts with what?
Z.
3. Zep. Doesn't it? Zeppelin. And we used to say, what do you find at a Zeppelin concert? A bunch of minors on tranquilizers. So that linked what? Zep with minor tranquilizers, so that we kind of remembered that. Okay. The prototype is Valium, diazepam, lorazepam, fluazepam, clorazepam, chlorzapoxide. They always have ZEP in them. Indications, they are more than just minor tranquilizers. These drugs are more than that. Yes, that's their major use. But letter A, they can also be used as a pre-op to induce anesthesia. Letter B, they can be used as a muscle relaxant. Letter C, they're good for alcohol withdrawal. D, they're good for seizures. And E, they help people when they're fighting the ventilator. They help them relax and calm down. Okay, number 5. Yes?
Do they put the generic and the brand name on?
On boards, they're going more and more for the generic. used to be that they always put both. About 2 years ago, they started flooding the exam with experimental questions where they only gave generic name for drug. Because they were trying to find out which drugs is it reasonable to expect new graduates to know by just the generic, and which ones would it be totally unfair to ask them by just the generic. That happened 1.5 to 2 years ago. It'll be 2 years this June. So usually questions stay in the experimental phase for about 2 years, maybe less. So pretty soon, all of those are going to start counting. Okay? Up until now, I would have said, no, they don't count. They're still in the experimental phase. But it's been long enough that they've been doing that yes, there probably will be questions on your board where you are given a drug just by its generic name. And you have to know what it is. That's why I'm trying to do phenothiazines, benzodiazepines, calcium channel block, dipines, sones, those kinds of things, so that you learn the generic names, the mycins, rather than the actual trade. Now, don't panic, because if the only questions that have generic name only, the only questions that have made it into the test pool are ones that are reasonable to expect a new graduate to know. So it's not going to be one that you probably wouldn't know. It's probably going to be one you would know anyhow, like acetaminophen, okay, or warfarin, or meperidine, or acetylsalicylic acid, or those are, you should have known what all those were. What was warfarin? Coumadin. What's acetaminophen? What's acetylsalicylic acid? What is meperidine? Demerol. So those are things that you need. Those ones would be like there. They probably won't say something like, I doubt that they would say pantoprazole. They'll probably say Protonix, or Protonix pantoprazole. You see what I'm saying? So yes, there's a big trend to make it generic only, and I don't like that. I think that's stupid. I don't understand the point of it, because you can always look a drug up. So I don't understand why that's, what's unsafe for nursing practice is not looking up a drug, not having the PDR memorized. Do you see? So I don't know where they're headed with it, but I'd like you to really, from now on, if you work, learn your generic names. Learn your generic names. Call them by their generic names. Until you take your boards, then you can call it whatever you want. Yes? Oh, I thought, okay. Just praising the Lord? I didn't know if that was it. Okay. Number 5, they work quickly, but you must not take them for more than 2 to 4 weeks. How many of you know people that have been on Valium for years? That's not what the FDA ever approved. So what's the relationship? Think about this. What's the relationship between an antidepressant and a minor tranquilizer?
When you take 2 to 4 weeks, and one you don't.
Right. So one takes how long to work? 2 to 4 weeks. And that one you can be on for how long? Rest of your life. However, the other one works right away, but you can't be on it for longer than 2 to 4 weeks. So if somebody comes in anxiously depressed, they'll throw them on both an antidepressant and a minor tranquilizer at the same time on admission. Why? What's going to make them feel better right now? The minor tranquilizer. But somewhere in the next 2 to 4 weeks, what's going to kick in? Their antidepressant, and then you pull them off the minor tranquilizer and they go home on the antidepressant. So stay on your tranquilizer until your antidepressant kicks in. Another analogy, can I make another analogy for you? Heparin is to Coumadin as a tranquilizer is for an antidepressant. Heparin is to Coumadin as a tranquilizer is to an antidepressant. Did you get the analogy? Heparin works how fast? Right away, but you can't be on it for very long. Coumadin takes longer to work, but you can be on it for the rest of your life. And you're only on your heparin until your Coumadin kicks in. Well, that's the same relationship between a tranquilizer and an antidepressant. Okay. Turn the page. Let's talk about the side effects. A, B, C, D. Do I have to repeat them or can you write them down? Anticholinergic, dry mouth, and constipation. Androgenes. Blurred vision. A, B, C, D. And the number one nursing diagnosis is, because it's a tranquilizer, safety, injury. Are you seeing anything different from the major versus the minor? Just a few side effects. Okay, which brings up the monoamine oxidase inhibitors, the MAO inhibitors. These are antidepressants. I don't understand why they're still being tested on boards. It has been 17 years since I gave one of these. And it's not because I didn't work psych, because I did. And I taught psych clinicals too. So I don't know why they give them. Now, they still give them in Veterans Administration hospitals. You'll see the most likely place you'll see an MAO inhibitor given is a Veterans Administration hospital. Why? And they're dirt cheap. Dirt cheap compared to the other antidepressants. You can buy a month's worth of MAO inhibitor for the price of 3 days of Prozac. You know, they're pennies. They cost pennies per pill. Now, number 2 tells you how they work. You can just read that yourself. It's not a big issue. But the drug names, you need to spot an MAO inhibitor when you see it. Now, you're going to spot it from the beginning of the name, not the end of the name. The beginnings of the names all rhyme. They are Mar, Nar, and Par. Mar, Nar, Par. Mar, Plan, Nar, Dill, Par, Nate. You see it there? Mar, Plan, Nar, Dill, Par, Nate. Now the only problem with Mar, Nar, Par is that is their trade name, not their generic. Okay, but I've not seen a lot of generic names on these on standardized tests. Almost every standardized test I ever see has the Mar, the Nar, and the Par there. Side effects. Write it down. But the number one thing they test is on page 67. Patient teaching. Do you remember these drugs? Letter A, to prevent severe, acute, sometimes fatal hypertensive crisis. Hypertensive crisis. High blood pressure. Hypertensive crisis. The patient must avoid all foods containing tyramine. Remember this one? This is that diet that they're not allowed to have certain foods. I saw this once, and I was the one that took the blood pressure in the ER, and I got 300 plus over 220. And the only reason why I wrote 300 plus was back in 1978, our manometers only went up to 300, so who knows what it really was. But it was I wish I had a Dynamap back then, but they weren't invented yet. See, when I was a nurse, all we had was metal IV needles. We never had the plastic. We had metal needles stuck in people for try to get somebody through a shift without a metal needle infiltrating. Well, you care. Okay. So you have to know what foods have tyramine, which foods they're not allowed to have. They test this all the time. Every time I try to pull this out of my lecture, somebody says it was on my test, and I say, okay, put it back in. Okay, here are the foods you're not allowed to have. In the fruit and veggie food group, generally speaking, fruits and veggies do not have tyramine. So these people can eat all the fruits, all the veggies they want till the cows come home. It's no problem. Just have at it. However, there are 3 fruit veggies that they're not allowed to have. And I always say, remember the salad bar. B-A-R. The salad bar. B for bananas. A for avocados. And R for raisins, which actually stands for any dried fruit. They're not allowed to have any dried fruit. Now be careful, because on certain tests, including the boards, they're very likely to talk about guacamole, which is what? Avocado. See, they always do that kind of thing where you almost have to be a cook to know what's in foods. But guacamole. Now, number 2, grains are fine. They can eat cookies, pie, cakes, breads, no big deal. Meats, they're not allowed to have organ meats, so no liver, kidney, tripe, intestine, brains, heart, lung, tongue. No preserved meats, which means nothing smoked, dried, cured, pickled, or anything like that. Now, they're not allowed to have hot dogs and certain processed lunch meats. Why? What's the last thing in the label on a hot dog?
All the organs, like right
And
there.
other assorted parts, which means heart, lung, tongue, kidneys, brains, intestines, the whole shoot match. Now, my entire family, back one generation, is Slovak. My grandparents and my dad were not born in America, so I'm first generation American. But in Slovak, we ate Slovak foods, and heart, tongue, lung soup, all that fantastic stuff. And heart and tongue are great. They're fantastic. Back when I was in high school, the big rage in the 60s was to steal other kids' lunches and eat them. No one would touch my lunch. I could leave my lunch out as long as I put Mark Clement on it. Nobody would touch that bag because they never knew what was in it. Okay. Dairy. They're not allowed to eat cheeses except for cottage and mozzarella. Now, there are a few other cheeses they are allowed to have, but boards just really wants to know, can they eat mozzarella? Can they eat cottage cheese? Yeah. So those aged cheeses are no good for them. And also, they're not allowed to have yogurt. This is probably the only diet where yogurt's bad. And then number 5, I know this is not a food group, but for some of you it is. No alcohol or chocolate, okay? So no alcohol, which rules out elixirs, tinctures, no caffeine, which rules out chocolate, licorice, soy sauce, all of that. So those are the things they're not allowed to have. And B, teach the patients not to take over-the-counter meds when they're on an MAO inhibitor. Have you ever read drug labels at a drugstore? What do they all say? Don't take if you're on an MAO inhibitor. Classic. Okay, lithium. We talked about it a little bit yesterday, didn't we? Notice it's an electrolyte like potassium, magnesium, calcium. Isn't lithium on the periodic table of chemistry? Second row, first column, Li, lithium. It's used for treating bipolar disorder because it decreases what? What did I say yesterday? Mania. It does not treat what? Depression. It decreases the mania. You're going to find out that of all psych drugs, lithium is the most unique because its side effects are not A, B, C, D, or any variation thereof. The reason is all other psych drugs, other than lithium, are what I call neurotransmitter messer-withers. Okay? They have their action by what? Altering neurotransmitters. This drug is the only psych drug which does not mess with neurotransmitters. It stabilizes nerve cell membranes. So because it has a unique action, it will have a unique set of side effects. And its side effects will act more like an electrolyte. So it will have the 3 P's: peeing, pooping, and paresthesia. Peeing, pooping, and paresthesia. Why paresthesia? Why will this drug have paresthesia as a side effect? What did I say yesterday about electrolytes?
No, 41.
The earliest sign of all electrolyte imbalances is numbness and tingling, paresthesia. So if you give somebody large doses of lithium and make their lithium high, first thing is numb and tingling. Now, what do you do if someone on lithium is peeing, pooping, and paresthetic? Give the drug, hold the drug, call the doctor, don't call the doctor. Which ones? Give and don't call. You can tell him later on when he comes in. However, number 3, toxic effects. What are we going to do with these? Hold and call. Okay, tremors, a metallic taste, and severe diarrhea. Tremors, a metallic taste, and severe diarrhea. Those are the toxic effects. Now, letter A should actually be pulled out to the margin. It really doesn't belong under toxic. I need to switch that. Number 1 intervention when someone is on lithium is increase fluids. The number 1 nursing intervention when someone is on lithium is make sure these people get ample fluids. Why? What are they doing all the time? Peeing and pooping, which makes them lose fluid, which makes them high risk for fluid volume deficit dehydration. So what are you watching? What other blood value are you watching? Dehydration. What other lead value are you watching? Sodium. Okay, letter B, if they are sweating, like they're outside work, and if they say you got a lithium patient, he's manicky, and he's out re-roofing everybody in the neighborhood's house, because they get that way when they get manicky and it's 90 degrees and they're sweating like crazy, don't give them free water. Give them like Gatorade or some electrolyte solution, because you'll be in real trouble, because you have to have a normal sodium for lithium to work. Number 4, note, lithium is closely linked to sodium. So when you're on lithium, you must monitor the sodium levels. Low sodium makes lithium more toxic. High sodium will make lithium ineffective. So if sodium's low, lithium's toxic. If sodium's high, lithium won't work. So the only way lithium will work is if sodium's what? Normal. That's why, in addition to monitoring the lithium level, you got to monitor the sodium level. Otherwise, you don't know what you're doing. So watch that sodium level when somebody's is on lithium. They're called competitive binders. Have you ever heard of that term? Okay. Prozac, everybody's favorite drug. Prozac is a selective serotonin reuptake inhibitor. It is similar to Elavil, the non-selective serotonin reuptake inhibitor. So the same set of side effects belong. So what are the side effects for Prozac? A, B, C, D, and euphoria. However, number 3 is more what they're going to test. Prozac causes insomnia. So give it before noon. Do not give Prozac at bedtime. Not a good idea. Number 4, when changing the dose of Prozac for an adolescent or young adult, watch for increased suicidal risk. What age group? Adolescents and young adults only. Now, if I were on Prozac and the doctor changed my dose of Prozac, would you have to watch me for increased suicidal ideation? Yes or no? No, because I'm not an adolescent or a young adult. I may look it, but I'm not. If you think that's true, you need glasses. The other thing is, what if an adolescent is on Prozac? Does that make them increased risk for suicide? No. It's only when you change the dose. So you have to have both. In order to say there's increased suicidal risk, you have to have recently changed the dose, and they have to be an adolescent or a young adult. If you changed my dose, it wouldn't be increased risk. And if you kept their dose the same, it wouldn't be a risk. It's only when you change the dose for an adolescent. Which brings up the last three drugs, then we'll take a break. Haldol, my favorite drug. I love Haldol. Give me a Haldol and a dart gun and I'll be happy and psych all year long. It has a decanate form, which means what? Long-acting IM that you can zap somebody with. It's basically the same as Thorazine. So what are the side effects? A, B, C, D, E, F, G. This is also called a typical first-generation antipsychotic, just like the zines are. It's the old drugs, the old antipsychotics. The big thing they'll test with Haldol is NMS, and you must know NMS. Do not go to boards not knowing what NMS is. Elderly patients and young white schizophrenics also may develop NMS from an overdose of Haldol. NMS is neuroleptic malignant syndrome. It is a potentially fatal hyperpyrexia. That word hyperpyrexia means fever, with temps of potentially 106 to 108. Certainly over 105, but it could start at 102, but it's going to go up, way up. Therefore, the dose for elderly patients should be half the adult dose. But the big thing they're going to do, how they'll test this is this. NMS also has some tremors with it, and anxiety and tremors. EPS has anxiety and tremors with it. And you get EPS and NMS with the same drugs. So boards is going to want to know, do you know the difference between EPS and NMS? EPS is a side effect, no big deal. NMS is a medical emergency, huge big deal. Patient could die. So they're going to want to know, do you know the difference between EPS and NMS? Because one's a big deal and one is not. How do you tell the difference between EPS and NMS? Take a temperature, which any LPN and any nurse, RN, could do without a doctor's order. So there's no excuse for any nurse missing EPS versus NMS. So if they tell you that you've got a patient on one of these major tranquilizers and he's having tremors and anxiety and confusion, what would be the first action you would take? Take their temperature. And if it's 102, 103, 104, what do? Immediately call squad if you're in a nursing home or a psych facility. If you're in a hospital, call an emergency response team. You know what I mean? It's going to be a bad situation, yes.
So temperature above 102?
I would say, yeah. Even though classically it's the 106 to 108 range, if it's over 102, you call that. Leonid, half the time, when you call 102, they're going to be okay. So you have to call them, even though you know that not everybody with a 102 is going to be actually in NMS. You can't. It's so life-threatening. You have to do it. That actually happened to us last spring when I was a nursing instructor at a certain hospital with some Cedarville students. We had a guy that was just a nervous wreck, and the patients were saying he's not himself. The nurses and they were trying to figure out what was wrong. And so I told my student, I said, "Go measure his temperature." So the student went and measured his temperature. It was 102.8. So we called the doctor, came in, got everything set, and I'm thinking, why didn't these nurses do this? But sometimes you forget those basic kinds of things when you're a nurse. You're thinking about a million things. So you do see it, and it's common. All right, Haldol, number 3, there are safety concerns related to the side effects. I love Haldol because if somebody comes in the ER and they're acutely psychotic and they're tearing the place up and they're wild and crazy, hit them with some Haldol. And then what we like to do, although I never have done this officially, although unofficially I've done it all the time, it's fun to take bets on when they're going to hit the floor. 5 minutes, 10 minutes, 20 minutes, because it's almost. Have you ever seen those wildlife shows where they shoot the rhinoceros in the rear end with a dart gun, and it runs around, and then all of a sudden, what's it do? Bam, like that. Well, that's what happens to these guys. They run around, and all of a sudden they go, bam, and they hit. It's kind of fun to watch. No, it isn't. I don't make a good psych nurse because I find things way too entertaining. And I've got lots of advice, and you're not supposed to give advice or think things are funny. Sorry, they are funny sometimes. Okay, Clozaril. Clozapine. What's the big danger with this drug? Name-wise. Look at the name. What's the big danger with the name? ZAP. Z-A-P. Which, if you're not careful, you think says what? ZEP. Z-E-P, and you'll miss what this drug is. Question?
With Haldol, if they're in this medical emergency then, with the MS, would you hit them with fluids? Is there
No, you just stay with your patient. There's not much you can do. Just make sure the vital signs are stable. You're with them, the squad comes, and then they'll manage them medically at the hospital. Many people die because there's not a whole lot we can do for it. It's not a good thing. Clozaril, clozapine, this is the prototype. Do you know what I mean by prototype? What do I mean by prototype? The original first. This is the original first, second generation, atypical antipsychotic. This is the new class for the zany. Number 1, it is used to treat severe schizophrenia, which the zany. It was meant to replace the zines and Haldol. It was originally developed to replace the zines and the Haldol. And it looked real promising at first because it had an advantage. Number 2, it had an advantage. It does not have the side effects A, B, C, D, E, or F. Now, it can have slight effects like that, but very, very minor compared to the zines and Haldol. Patient doesn't even notice usually. So originally we thought this was going to put the zines and Haldol out of business. But then after it was on the market for about 6 months, we started to see a problem. And what was that problem? Number 2, the disadvantage. It does have the side effect agranulocytosis. In fact, this drug is horrendous in trashing your bone marrow. Your white count can fall horribly low, and you can get unbelievable infections from being on this drug. So they then they altered the formula, came up with different drugs like Geodon, Abilify, Zyprexa, Olanzapine, and all of those. And those are variations of this Clozaril. And some of them are less likely to mess up your white count, some are just as bad. The thing is that not everybody gets the low white count when they're on these drugs. So the upshot is some people can take this drug and some people can't. But the big thing you got to know is with any of your atypical antipsychotics, white count is a big deal. Measuring the white count is a very important nursing monitoring function. The only thing I do want to say is I want to say something about Geodon. Geodon has a black box warning, which means a fatal drug situation. And that is Geodon prolongs the QT interval and can cause sudden cardiac arrest. Geodon prolongs the QT interval and can cause sudden cardiac arrest. Therefore, you shouldn't really use Geodon with people with heart problems. In general, your second generation atypicals end in the ending Z-A-P-I-N-E, zapine. So, once again, a tranquilizer class ends in a Z. So you have your zines. What are your zines? What are your zines? Typical old-time antipsychotics. What are the zapines? Second generation atypical new antipsychotics. And what are the zeps? The minor tranquilizers. Okay? So zine, zapine, and zep are all your tranquilizers. One's an old major, new major, minor. You got that? Can you match them? Minor, old major, new major. Zep, zapine, and zine. Okay, the last drug, Zoloft. They are loving Zoloft, and they will call it sertraline, not Zoloft. It's another SSRI like Prozac. It also causes insomnia, but you can give it at bedtime. But the big thing they are now testing more and more with sertraline is the interactions. Has anyone ever heard of the cytochrome P450 system in the liver? What is it responsible for? Cytochrome P450 system in the liver. It's the major enzyme pathway by which drugs are broken down and deactivated in the liver. You remember how drugs are detoxified, deactivated in the liver? Well, the cytochrome P450 enzyme system does that. You don't have to write this down. Zoloft, sertraline, is notorious for interfering with that system, the cytochrome P450 system. So what does it do when you take other drugs? Increases toxicities because they aren't broken down. So the reason why boards and other ones are testing sertraline is because when you're on sertraline, other drugs don't get metabolized and you have problems with too high levels of the other drugs. So when you add sertraline to the drug regimen of a patient, what do you probably have to do with all the other drugs they're on? Lower the dose. Okay, so let's talk about this. Number 3, watch for interaction with St. John's wort, this herbal preparation that people are taking right now. If you take St. John's wort and sertraline together, you're going to get serotonin syndrome, which is a potentially life-threatening problem. It looks a lot like those MAO guys that eat the tyramine. Looks a lot like that. So what are the symptoms? I remember the symptoms from SAD head. S for sweating. A for apprehension. D for dizziness and headache. So they sweat, they're apprehensive, they're dizzy, and they have a headache. Now, apprehension is often called an impending sense of doom. Have you heard of that? Mm-hmm. That's what we mean by apprehension. But the big one is its interaction with warfarin Coumadin. And that is when you're on sertraline and Coumadin, you're going to bleed out. You've got to reduce that Coumadin. So watch for increased bleeding. When they're on Coumadin and sertraline, watch for increased bleeding because the Coumadin is going to go toxic. All right, take a break. Come back at 5 after. We're getting there. Yeah.